All right, so we're going to cover chapters 2, 3, 4, and there's one other one off the top of my head. We're going to do those today. So the first one we're going to do is workplace safety and wellness. So these chapters are all things that we have to do. Unfortunately, they're probably the most boring chapters that we have in the book, but also some of the most important ones we have to deal with, including documentation, medical, legal, and things like that. So we're going to cover the workforce safety and wellness this morning. So obviously the National EMS Education Standards competencies, it tells us we have to go through in order to meet the requirements to become an EMT. So medicine obviously applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. So what they want us to do is go in, make an assessment with our knowledge that we take at the levels that we're at, and with that form a general impression, come up with a diagnosis, and then treat. Another part of it would be infectious diseases, so the awareness of how to decontaminate equipment after treating a patient, and assessment and management of how to decontaminate the ambulance and equipment after treating a patient as well. So, I mean, obviously we're seeing that now more than anything. Before this program was written, when this program was written, obviously COVID-19 wasn't out there yet. It was there, but not at this stage of it. So COVID was still always around, but the COVID-19 was not. So we've seen a whole different way of how we're approaching patients to decontamination, using different sprayers and things like that. And I'm sure that you guys have been around the fire job enough that you've seen this or work in a hospital or whatnot. It's like most recently, I had a call the other day where not only did the patients have COVID and were very sick in the home, but they were also full of feces all over the ground and urine and everything else. It was just a situation where we had to actually have fire come in and use SCBAs to get the patient out. The patient ended up getting RSI'd and intubated in the back of the ambulance, and then transported to the hospital just because due to the COVID-19 exposure. So again, for us taking care of our own personal selves, I mean, we were N95s, gowns, goggles, surgical masks. As you can see, a lot of things have changed. You guys can speak in any time you want, but just the world has changed completely, and especially more towards healthcare. We're definitely seeing the differences here. And just the decontamination process used to be just wipe stuff down. Now we're spraying, wiping, venting off. So it's a whole different world now compared to what it used to be. Preparatory applies the fundamental knowledge of the emergency medical services system, the safety and well-being of the emergency medical technician, medical, legal, ethical issues to the provision of emergency care. That's the next step. 4 would be workforce safety and wellness, looking at standard safety precautions, personal protective equipment, stress management, dealing with death and dying, and preventing of response-related injuries, prevention of that. And then last would be the workforce safety and wellness, prevention of work-related injuries, lifting and moving patients, disease transmission, and wellness principles. All right, so to take care of others, we must take care of ourselves. So by saying this is, we need to make sure that we're mentally prepared. So if we're having issues at home, it's hard sometimes to come into work because those issues tend to travel with you. But vice versa, though, you have issues at work and you bring it home to your family, what does that do at home? You know what I mean? So you got to find a way to vent, find a way to kind of release, whether that be go out and doing ATVing, jet skiing, going out for hikes, walks, bike rides, or sitting down and watching a movie, or sitting out by a campfire. You got to find a way to have yourself release. You got to be able to just relax and try to leave stuff at work and leave your home life at home. When you start bringing your home life to work, then it kind of interferes with that. And then at that point, you're not going to be able to treat your patients accordingly to your best ability. Another thing also is sleep. You need to make sure you're getting enough sleep. Yeah, I know we say sleep, and we all work 80 to 100 hours a week. But you have to find time for to relax. So take care of yourself. If you can't take care of yourself, taking care of others is just not going to happen. EMT training also includes recognition of the hazards like personal neglect, environmental and human-made threats, and also mental and physical stress. Some other general health and wellness stuff would be wellness in this is a state of complete mental and physical and social well-being. So again, like I mentioned before, we have to take care of ourselves. A state of wellness must also occur at work and at home. If you can't have a good work-home balance, something's going to give at some point. Some components of wellness would be protection from disease and hazards. And I can tell you with the COVID-19 stuff, I'm sure you guys are sick and tired of hearing about it. Just the process of having to put the gowns on, the pappers on, every time you come in contact with a patient that has respiratory symptoms, it just takes a lot out of you. It really does. It's not the same as it used to be when you hopped in the back of the ambulance, no mask, and started treating people that had COPD. Maybe they had the flu, you didn't know, unless you checked temperatures and things like that. We just kind of went in, did our thing, and we had our flu vaccine, so we thought we were good. But if you noticed, as far as wellness goes, since we've been wearing masks, nobody, I say nobody, 98% of the people haven't gotten the flu at all. So a lot of things have definitely changed, and a lot of protection with that. Proper nutrition, eating healthy, making sure you stay in shape, using sufficient exercise, getting enough sleep. Also refraining from tobacco, drugs, and alcohol. And just taking time to just relax. Sit back, relax, close your eyes, read a book, just kind of unwind at that point. Remember that EMTs often work in a stressful situation. Most of the calls we go on can be stressful, depending on the severity of the call, from your level to a patient who is not doing well. As an EMT, your role is to be prepared, be ready for the call. Anticipate needed resources. So as you're responding, what do we need for other resources coming in? Do we need fire apparatus, a second ambulance, paramedic response? Also to control the scene. So when you get there, if you're the highest license level, you have total control of the scene. If you have 2 EMTs on the truck, the senior EMT, or if you have a supervisor on the vehicle, they're the ones responsible to control the scene. And then we need to take care of our patient. Your calm manner will calm the patient, family members, and also bystanders. This is a very true statement. If you walk in freaking out, shaking everywhere, what does that do to your credibility? You know what I mean? So if your credibility is low, the patient starts getting scared. You start freaking out, calling for a paramedic on the radio. What does that do to the family? It's simple as just being calm, making a paramedic request, and just treat your patient. Remember ABCs: airway, breathing, circulation, and work your way through from there with your assessment. Stress in any event, thought, or action perceived as a threat. Regardless of how stressful the situation may be, you must focus on in this order: personal safety first, scene safety, including safety of everybody else, and then patient care is last. So in regards to the event that I had the other day, just with the odor coming out of the building, the state of what was going on inside, and just the hazardous materials, feces, dog feces, and dog urine literally covered the whole entire floor. It was that point where I made a decision that we're not going to send EMS personnel in without their proper equipment, and with that would be SCBA's turnout gear. So fire came in and removed the patient, brought him out to us. So sometimes you may have to make that determination to figure out what is safe for you and your crew before we start getting into patient care. Some strategies to manage stress would be minimize or eliminate the stressors that are there. Find your way to eliminate them if you can, or minimize them. Change partners to avoid a negative or hostile personality. So looking at crews that are assigned, if you have just you and one partner with no other ambulances on, it's hard to move stuff around. But if you have a big enough ambulance system where you can move people around in different partners to make things better, we can do that. Change in work hours. If 24-hour shifts or 48-hour straight shifts are too much for people, which it can be for some, they also offer other variations of shift hours depending on if you're working private EMS versus municipality and things like that. Change the work environment. If you are in a busy city system and they have an outskirt, more rural system that you want to jump into, sometimes making that change actually helps out. Um, and also cut back on overtime. Yeah, I understand that some people need the extra hours, but sometimes just taking a week off of overtime can actually make a huge difference in life. Change your attitude about the stressor. Talk about your feelings. I know it's hard for some people to do, but if you go home and have a conversation with your significant other to talk about what's going on, as long as you keep HIPAA stuff HIPAA, you can still talk about how your day went. There's also the availability, if you're on fire departments, to have like a department chaplain to talk to, or just another coworker, whatever it may be. Seek professional counseling if needed. A lot of times the services that you work for will actually cover counseling sessions. If you need to kind of find someone to talk to based on maybe a bad call. Some bad calls would include like a pediatric cardiac arrest. It's one of the toughest calls to go on. You go to a cardiac arrest with a 98-year-old person, and they've lived 98 years. It doesn't hit you as hard as it would be if you go to a pediatric cardiac arrest, and it's even worse when you have your own kids. And then you see another kid pass away in front of you and you can't get him back. So sometimes you may need that extra counseling to kind of have someone to talk to. Do not obsess over frustrating situations. Just walk away, take a deep breath, come back and revisit it later. Expand on your social support system. Remember, you don't just have your family at home. There's people out there that can also help. You have friends, coworkers, things like that you can talk to. Develop friends and interests outside of emergency services. If you go home and all you do is listen to a scanner all day, sometimes that can be a problem. It's always good to go home, turn that pager off, and just go find something else to do. Go check out waterfalls, go for a hike, go for a bike ride, four-wheeling, whatever, anything that you can do outside of it that does not involve fire and emergency services. Have a way to release and get away. Minimize the physical response to stress, periodically stretching or yoga, slow, deep breathing, regular physical exercise, meditation if needed. Even if you're on shift, just if you're not doing anything, just take time to stretch and just loosen up a little bit. A lot of times that will make a huge difference. And they also say limit the intake of caffeine, alcohol, or tobacco. I used to drink a lot of caffeine, and I was finding myself to be even more tired throughout the day. So now I've switched to either something with zero sugar or just water in general. And my energy level has gone tenfold, so much better throughout the day. I'm not tired, not trying to fall asleep. So just making little changes can make a huge difference in how you feel throughout the day. As far as nutrition goes, obviously eat nutritious food. Physically prepare your body for stress. So when you're working private EMS, which some people may end up going into, and you're stuck on transfer after transfer after transfer, and the only place open is McDonald's. You stop at McDonald's, grab fast food. This is one of the worst fields to get into when you're trying to eat healthy, because the dispatchers are always like, hey, you got another call pending, versus the firehouse atmosphere, where if you go back to the firehouse, a lot of times either your probie or rookie or whatever may make dinner for everybody else. Usually they can prepare something that's a little bit healthier. There are still ways to eat healthy even doing private EMS, and that's just bringing your own stuff with you. Or, if you have another transfer coming in, if you're doing a transfer truck, call in an order and then swing by, grab it really quick for someplace might be a little bit better to eat. Try to find different snacks throughout the day that are not involving candy bars and sugar, but other things that might make you feel a bit better. Exercise and relaxation, and then obviously sleep, regular and uninterrupted. That means pagers off, go home, get your 6 to 7 hours of sleep, and it helps you recharge for the next day. Disease prevention is know your family's health history, and then adjust your lifestyle. Prevent yourself from diabetes, prevent yourself from getting hypertension, things like that, where you can work on your food intake and fluid intake to help make these changes. Balance work, family, and health. So rotate your schedule. Take time off. There's vacation there for a reason. If you work 2 24-hour shifts a week, that means you only work 8 days a month. It means you have 24 days off a month to go do something different, to kind of take some time off. Not only that, they also give you vacation time. So if you have 2 weeks vacation, you can plan it out to the point where you almost have 3 weeks off of work. Other infectious disease is also caused by organisms within the body. You can't help fight off disease if your body is worn down and tired. Communicable disease is also spread from person to person or from species to another, one species to another. So from like a dog, cat to another human. Again, we need to protect ourselves even more now than ever. People say COVID is fake. COVID is definitely real. I mean, I've come in contact with it. I've seen it. I've seen how sick people actually get from it, and I've seen people die from it. It's there. We need to protect ourselves, whether that be with the N95s. I'm not here to tell you guys to get vaccinated. That is on your own choice. However, Maine EMS requires you to be vaccinated now in order to hold an EMS license. So, again, it's up to you guys what you guys want to do. It's your body. That's my own opinion on this. But protect yourselves best you can. Infection risk can be minimized by immunizations, protective techniques, and hand washing. We're going to go over some more terminology as well with pathogens, contamination, and exposure here in a little bit. Some routes include direct contact, so bloodborne pathogens. EMS, we're going to deal with blood. It's going to happen. Indirect contact with needle sticks. Needle sticks do occur. They should not be occurring as much as they actually do out there. You need to protect yourselves. A lot of services have gone to either needleless systems, or if they do have needles, they are protected with devices that actually helps secure the needle after you're done using it. So the days of the old paramedics taking the needle and sticking them into the bench seats are gone. If that stuff's still happening, yeah, maybe it's time for them to get a little re-educated. Airborne transmission, obviously sneezing and things like that. We do have masks to help us protect from that. Foodborne transmission, which would be contaminated food, like botulism, things like that. And then vector-borne transmissions like fleas. As you can see here, you notice this guy has an infection in the finger. This can be caused through transmission through the cuticles of the finger. And obviously this guy here is sneezing, and you can see all the particles coming out. So all EMTs are trained in handling bloodborne pathogens. We are dealing with them on a daily basis, whether it be blood, fluids, vomit, diarrhea, feces, urine. It's all part of the job that we do. So the CDC helped develop standard precautions. Obviously, hand hygiene, washing your hands. It's to the point that Apple Watches actually, when you wash your hands, I noticed that mine does this. It actually says, "Oh, you're washing your hands," so it starts timing you to see how long you've done and whether or not you did a good job or not. Personal protective equipment, obviously gloves, gowns, masks, eye protection, face shield. And we're starting to see ourselves wear this more often because of the COVID-19 stuff. As far as the patient care environment goes, obviously soiled patient care equipment, environmental controls, textiles, laundry, needles, and other sharp objects. These are some of the patient care stuff that we have, and we're going to deal with soiled patient care equipment, whether it be from intubation blades after assisting a medic where we have to clean them and put them back in service. A lot of services have gone to the disposable ones now that are more fiber optic, which are nice. So the one use and toss them, so they're still clean and sterile in the next package you use. And some environmental controls that we have, obviously utilizing different airborne stuff that kind of clean, like the sprayers that we have now too. So they have something called HALT. I'm not sure if you guys are using them in your services for your ambulances or not, but we spray our ambulances once a day where we are. And anytime we have a COVID patient or any kind of suspected COVID patient, we spray with the HALT sprayers to help disinfect the inside. Most facilities have laundry facilities in-house, so make sure you bring spare clothes. if you get in contact with any kind of exposure of some sort, don't put them in a bag or bring them back to your own personal laundry at home, your own washer and dryer. Go to a laundromat, clean them there. Don't bring that stuff back to your residence, especially with your kids. Don't toss it in your vehicle. If you do have a pickup truck, throw it in the bed of the truck. If you don't, double bag it, put it in the back, things like that. So special circumstances, obviously patient resuscitation and respiratory hygiene and cough etiquette. If you have to cough, remember always cough into your bicep, into your arm, if you need to. Help prevent it. Hand washing is the simplest yet most effective way to control disease transmission. And that's not using the hand sanitizer. That's actually utilizing soap and water and going through 21 seconds of washing your hands. Wash hands before and after the patient contact, even if you wear gloves. And I've noticed lately that the gloves are becoming more and more weak. And I noticed that they keep breaking. So I've seen some people actually double glove to help with that. If there is no running water, you can use the hand washing substitute, which is the hand sanitizer. It does kill like 99% of the germs that are on your hands. However, there's still that potential chance you could have some kind of transmission. So soap and water is one of the best things to utilize when washing and taking care of your hygiene. So wear gloves if there is any possibility of exposure to blood or body fluids. They have vinyl, nitrile, and latex gloves, which are effective protection. Maine EMS has gotten rid of latex completely, and all ambulances need to be latex free. New Hampshire has gone the same way as well. So make sure you're always wearing gloves. Anytime you have a patient contact, you should be wearing gloves.
Hey, Kevin, can I ask a quick question?
Yeah.
So I'm just processing that laundromat part. Now, why is the laundromat? Are you still exposing people there?
You are.
And wouldn't you like contract more diseases and stuff in the laundromat?
So
there we go.
I've always been told to use the laundromats because they come in and they bleach and clean stuff more often.
Oh, okay.
Yeah.
No, I was just thinking when you go to a laundromat, you take your stuff out, somebody else puts it in.
But a lot of times, if you go to different laundry cleaners where they can actually clean laundry there, they do it for you. They can do that.
I mean, our departments have their own washer and dryers. I was just wondering about that stuff.
Because some laundry facilities actually have a sanitized option as well.
Oh, okay.
So just different things that are out there to utilize. It's just better than bringing it home to your family.
Okay. That makes sense now.
Yep. No worries. So removing gloves require a special technique. So you need to avoid contamination with the materials on the outside of the gloves. When we do our practical days, we will show you guys how to take off gloves the appropriate way. I'm sure most of you already know, but we'll go over that more in detail. Eye protection and face shields. Anytime you're dealing with anything with airway management, you should have eye protection on. So I will mention this, when you guys are working in New Hampshire and you're putting in a king airway, patients do vomit and they do squirt up tubes. And they make it like a little bit of a geyser coming out. So you want to make sure you're protected if they do vomit into a tube like that. Prescription glasses are not adequate. You actually need to have the full protection of the eyes, including shields on the side as well. So goggles or face shields are usually the best. So I usually wear face shields. I wear glasses. So for me, I put a face shield on. It kind of protects everything along with a mask, and it protects my eyes. Gowns are provided from extensive blood splatter. That's what protection is there for. However, when dealing with COVID, we're wearing full gowns. So make sure you're wearing the appropriate PPE for the appropriate call. May not be practical in many situations. It also may even pose a risk for injury. However, again, we got to protect ourselves to the best abilities. Mask, respirators, and barrier devices. Standard surgical mask for fluid splatter. Then surgical masks on the patient with communicable disease. So anytime I have a patient with respiratory, they get a surgical mask, and I'm also wearing one as well with an N95. Masks are particulate air respirators on yourself if disease is tuberculosis. Again, you can tell this was made pre-COVID because this was back in 2017. So if we're seeing any signs of any kind of respiratory stuff, even when you're giving nebulizers in the back of the ambulance to assist, if you're assisting a medic or an AEMT, we're going to need to be wearing N95s if we're doing a respirator or a nebulizer in the back of the ambulance, just because the particles end up going airborne. But sometimes these patients still need to be treated, so we have to make sure we're in the appropriate PPE. Turn your exhaust vents on in the ambulance so it kind of pulls the particles out to the air and things like that. Mouth-to-mouth resuscitation may also transmit disease. That's why they have pocket masks and BVMs, back valve masks, to be utilized. And these here actually get disposed of according to local guidelines. We throw them out every single time. Once you use it on a patient, it's gone. We get a new one. Proper disposal of sharps helps avoid HIV or hepatitis. Every ambulance is required to have a minimum of 1 sharps container in the ambulance itself, and also you're supposed to have one in your first in bag if you're running an ALS service. Or you can dispose of sharps inside a residence if you're doing IVs or things like that inside. So know where the sharps containers are. A paramedic may hand you a catheter to say, hey, can you put this in the sharps container for me? And we'll show you guys how to properly dispose of those during our practical session. Do not recap, break, or bend needles, and do not throw them in the trash cans. There is no guarantee of 100% risk-free environment. Not at all. The risk of exposure to communicable disease is a hazard of your job. Know your department's infection control plan and follow it. Every department in the state is required to have a exposure control plan for their agency. It's a Bureau of Labor requirement, Maine, New Hampshire, and make sure you know it, follow it. And it also has all the forms and stuff that need to be filled if you do have an exposure as well. So establishing an infection control routine. So infection control should be part of your daily routine. Clean the ambulance after each run and on a daily basis. So in the morning, make sure the truck is wiped down. Like I said, where I work, we spray it with a Hald sprayer as well to kind of kill any infection that's in there. And then after every call, everything gets wiped down and put back in service. Now, if you have a COVID patient or respiratory patient, at that point, we use the Hald sprayer as well for that. Cleaning should be done at the hospital and whenever possible. Please do not take your ambulance and put it back in service if you have not cleaned it and go back to the station and start cleaning it over there. The hospitals provide all the necessary stuff to clean other than a Hald sprayer. And most services are getting the portable battery-operated guns to be able to use at the hospital to do spraying. So immunity. Even if germs reach you, you may not become infected. You may be immune to it. Preventative measures will be maintain your personal health and receive immunizations as required. So maintaining your personal health, that's just not just eating healthy, but that's making sure you get enough rest as well. When your body is tired and worn down, your body really can't help fight off the stuff you need to fight off. General post-exposure management. If you are exposed to a patient's blood or bodily fluids, turn patient care over to another EMS provider, clean the exposed area, rinse your eyes if necessary. Remember 20 minutes of eye rinsing. Activate your department's infection control plan and complete an exposure report. That way there, even if you have the smallest exposure, still fill out an exposure report because let's say 10, 15 days or even let's say 5 years down the road, something changes and they can relate that back to that incident, then you can be covered. All right. Let's see. So scene safety. So begin protecting yourself as soon as you are dispatched. So a lot of times, especially now with the COVID stuff, dispatches actually come back and if that alerted people, hey, this could be a, in New Hampshire, they use CC36 as the code for COVID-19. Again, if the criteria meets it, then what we're going to do is we're going to start preparing ourselves for protection, and then continue to protect yourself once on scene as well. As far as scene hazards go, this is an old book. Hazard materials will identify what you can see from a distance. Do not use unless safe to do so. The emergency response guidebook is really only good for the first 20 minutes of an incident, but it kind of gives you a lot of information to start to find out what the hazard is and things like that before you start working your way into moving forward with the rest of the incident. If you do have a hazardous response, it's not our job as EMS providers to handle this. You may have to call in specialized people, as well as far as hazmat teams and things like that. So electricity, so beyond the scope of EMT training, if we have an electricity issue, we want to mark off the danger zone. If it's lightning, remember that a strike can reoccur at any time. Either direct hit or ground current is possible as well. If we have a fire situation, remember that fire hazards include smoke, oxygen deficient, high temperatures, toxic gases, and building collapse. So for us, providing EMS or firefighter rehab, we want to make sure that we're away from the incident is far enough to protect ourselves, usually upwind, uphill from an incident if needed, or we want to make sure we're also staying out of the collapse zones as well. Because any time a building could collapse, and that could actually hurt us even more. So we want to make sure we're set up in a specific area that's going to help with that. Next one would be vehicle crashes. With vehicle crashes, some common events that we're going to respond to. Remember that if the vehicle is not stable, we shouldn't be going anywhere inside of it. We got to wait for fire to show up and make sure that the vehicle is stabilized at this point and safe for us to be able to go into, which we'll cover more in practical scenarios on vehicle incidents as well. There could be down power lines. There's a lot of sharp objects that are there. So we need to make sure we're using protective gear, things like that. If you're just using your normal attire, you really shouldn't be going inside of vehicles without the appropriate PPE. So a lot of times fire response, if you're working for a private ambulance, fire response will come in and remove the patient for you, bring them to the stretcher. So that may be another option as well. But if you're working for a municipality, most of the time you guys have the appropriate gear anyways, so should be pretty good. So protective clothing and preventing injury as well. So critical to personal safety. Make sure you have the appropriate PPE on. Become familiar with the various types that are out there. As you can see in the picture here, this person is wearing turnout gear to protect them from high heats inside of building fires and things like that. Also wearing the helmet as well and gloves. They do make gear just specifically for EMS providers that have flash protection, but you really can't go inside and fight a fire. But if something were to flash ignite, it does protect you to its best ability. Cold weather clothing as well. Remember, wear layers when you're outside, and then the turnout gear part as well. Some other protective clothing would include gloves, which will protect you from heat, cold, and cuts. It may also but it may reduce dexterity. So you have to remember what kind of situation you're dealing with. Another thing to also keep in mind with gloves is your gloves may not have bloodborne barriers inside of them. And if they don't have any bloodborne barriers, blood can actually leak through and get to your hands. So if you have a glove that is not bloodborne protection and you're working with someone that's not fire related, you're working with a patient, I've seen a lot of people put the non-latex gloves on and then put the fire gloves over them to protect it. Helmets is another one as well. Protect you from falling objects. Obviously, boots. Steel-toe boots are definitely preferred to wear. Also remember eye protection. So glasses with side shields. So if you're just wearing regular glasses, again, that's not protection for you. They need to have a side shield on. Ear protection, they have foam earplugs available. If you're outside in the sun for long periods of time, remember sunblock is good for you. And one thing they've added to this now is body armor, and that's something that we're starting to see more of. And most services actually have them on their ambulances, especially more municipalities. So caring for the critically ill and injured patient lets you know that let the patient know who you are and what you are doing. So when you come up to a patient, address yourself. So, hey, my name is Kevin. I'm a paramedic with the ambulance. I'm here to help you. What is going on today? What happened? And anytime you're performing a procedure, let them know what you're doing. Don't surprise anybody from anything, because you start doing stuff without them knowing about it. They may become startled. It could cause actually more harm. Also, the patient needs to give you consent to treat them. If they are alert and oriented, you have to get informed consent from them saying, yes, you can help me. If not, they can actually come after you for assault. So you gotta make sure you're asking permission. Do you mind if I help you? Now, if they're unresponsive and or altered mental status, then use the implied consent, as any right sane person would ever say, is be like, hey, I want help. So again, you can use implied consent if the patient is not able to answer your questions appropriately or is unresponsive. We'll get more into that during medical legal. Other responses of the critical patient would include anxiety, pain and fear, anger and hostility, depression, dependence, guilt, mental health problems, or receiving unrelated bad news. All these different things play a factor in as part of a response for a critical patient. And again, the anxiety could be a head injury causing the patient to become anxious. Anger and hostility could also be some kind of head trauma as well. So this is some things to think about and what we need to do to be able to treat these patients. If they're anger and have a lot of hostility, or if they're very anxious, there may be a need to have a paramedic come in for sedation to help treat these patients, because we can't help somebody if they're going completely crazy. You know what I mean? So we got to make sure we can do what we can to help treat these patients the best to our abilities. Communicating with the critical patient, obviously avoid sad and grim comments. So, I mean, I wouldn't go up to the patient that got into a motorcycle accident and say, hey, you look like a bag of hamburger helper. You know what I mean? These are things that you probably don't want to say to your patient. When you communicate to them, be factual, let them know what's going on, and just treat your patient. Be orient to the patient, be honest with them. One of the worst things you can do is say to a patient, everything's going to be okay. Because what happens if they die 3 minutes later? So again, we're doing the best we can to help you. Locate and notify family members as needed as well. Deal with possible initial refusal of care. A lot of times, these patients that are injured or may have fractured legs are like, I'm not going to the hospital. And I've seen that happen multiple times when they really need to go. And we'll get into more of that during medical legal and how to hopefully convince a patient to go to the hospital. Injured and critically ill children. Obviously, ask a responsible adult to accompany the child if possible. I've seen a lot of patients or family members that have said, here, take my child, and then they drive themselves to the hospital behind you. Death of a child is a tragic event, something we never ever want to have to deal with, but something that we could be responding to. Help the family in any way you can with this. Let the family's actions be your guide in what needs to happen. Don't give them too much advice. Let them kind of guide you to where you want to go with it, and prepare the parents for what's going to happen as well. One of the things that EMS classes in the past have failed on doing is not so much treating the critically ill. It's what they're failing at is to be able to go and talk to somebody after a death has happened. So dealing with the death and dying part of it and having that conversation with the family saying your loved one or your child has passed on, there's nothing more we can do. That's something that we usually don't talk about, because in the past we used to transport anybody. So if there was a dead body, we'd transport it to the hospital make the determination. Now, with all the new protocols that are out, we're actually working cardiac arrest, even at a BLS level, at EMT level, for 20 minutes. And then if there's no signs of life, at that point, we're calling it in the field. Now, at what point do you go talk to the family and say, we've done everything we possibly can? Unfortunately, there was no positive outcome. So we got to prepare ourselves for that mentally as well, to be able to let them know that their loved one is no longer alive. Death and dying. So death occurs quite suddenly or after a prolonged terminal illness. The ones that I've seen that have had the worst, I'm not going to say outcomes, the worst time to deal with would be the ones that die suddenly. The ones that have had prolonged terminal illnesses, a lot of times the family has had a chance to cope with the fact that they're going to pass on eventually, and then it's easier to communicate with them. A lot of them already have DNR orders, do not resuscitate orders in place. So at this point, they're kind of like expecting it to happen. They're still going to be sad that it happened, versus someone who is perfectly healthy that dies overnight in their sleep. So as an EMT, you will face death. It will happen. It will happen in your career. It could happen on your first call that you go on. Just make sure you're mentally prepared for it. The stages of grieving would be denial first. So that didn't happen. I don't believe it. This is not happening right now. To anger and hostility, where they start getting very angry with anybody that's around them. Then they start bargaining, saying, well, can we do this to bring them back? What can we do? Trying to make that bargaining part. Then they become very depressed. And then eventually they'll accept the death and move forward from there. So the EMT's role is ask how you can help. What can I do to help you? I recently had one, and then the 32-year-old female who ended up passing away, and I had to be there for the family initially. So I said, what can we do to help you? Reinforce reality to them, but be honest. And also allow the patient and the family to grieve. So don't be just all up in their faces trying to do more assessments. If they need to be with a loved one, let them be with a loved one. Just be there to help guide them if they need help. Some responding to grief on table 2.7 in your textbook. I say give it time. Things will get better. You should not question God's will. You have to get on with your life. You have to keep on going. You can always, I wouldn't say that. You can always have another child. Be careful when you're saying this kind of stuff. You're not the only one who suffers. The living must go on. I know how you feel. Don't say those kind of things. Instead, say, I'm sorry for your loss. It's okay to be angry. It must be hard to accept. That must be painful for you. Tell me how you are feeling. If you want to cry, it's okay. People really cared for whoever the name of the person might be.
So I'm asking on behalf of females because I know men are not as emotional as females are. Sometimes we just cry and we can't help it. Like if we end up being like really empathetic in a situation like that, is it okay? Like if we just take a second and cry?
It shows that you're human. It's okay.
Okay.
There's nothing wrong with that. You know what though? That actually shows that you really do care.
Yeah.
There's nothing wrong with crying if you need to cry. There's nothing wrong with that whatsoever. Just make sure that you understand that you are the professional. You're there for them. But there's nothing wrong with getting teared up or anything else. There's nothing wrong with that at all. You can also kind of step away too. Like if your partner is there with you and you know that you're really going to bawl your eyes out, you can always step aside, say, hey, listen, I need to step outside for a minute to kind of gain my composure. Go step outside, do what you need to do outside, and you can always come back in and then reassess from there as well. Utilize your partner to help you. So stress management on the job. EMS is a high stress job. Absolutely. Even if you're doing interfacility transports for BLS discharges, it's still a very high stress job because you could be up for 24 hours straight. You could be up running call after call after call, being behind in run reports, all different things that could happen that you might need that become very stressful. The important thing to know is the causes and how to deal with the stress that you're having. So find your stressors and then find a way to release the stress. Some general adaptation syndrome as well, alarm response to stress, reaction, and resistance, and recovery or exhaustion. So you need to go through these different steps and understand what actually helps you as a provider to relieve the stress that you have. Physiologic stress, signs of stress would be increased respiration and heart rate, increased blood pressure, cool, clammy skin, dilated pupils, tensed muscles, increased blood glucose level, perspiration, and decreased blood flow to the gastrointestinal tract. Some other stressful situations would be dangerous situations you come into, whether it be a motor vehicle accident with entrapment, motor vehicle accident with a vehicle on fire, things like that. Physical and physiological demands that are out there. You got a 500-pound patient on the second floor or third floor of the building, because that's where they always are, and you need to find a way to get this sick patient out and down the stairs or out the window, wherever it needs to happen. Critically ill or injured patients, patients that are very sick, very septic patients that are going to be dying soon if treatment isn't done, to the very injured patients where they are caught in a vehicle or fell 30 feet to the ground, is unresponsive with a closed head injury, things like that. Dead and dying patients, and then obviously overpowering sights, smells, and sounds. All of you guys know some of your weak points, I'm sure, whether it be the smell of feces, vomit, or the sound of someone vomiting, or whatever it may be, or different smells when you walk in. Vicks Vapor Rub will be your friend. Put that underneath your nose as you're going in with your mask on. A lot of times it can be your friend to kind of help reduce some of the smell. Multiple patient situations obviously can be very stressful when you show up to an MCI and you have 10 or 15 patients wounded or walking around. Angry or upset patients, family members, or bystanders. Unpredictability of demands of the EMS system. Non-critical, non-911 patients can be very stressful at times. And obviously hospital wait times. So we don't see as much of that up in Maine, New Hampshire, as you do in Massachusetts, where you bring so I've experienced with this down in Mass, where you bring a patient on a stretcher that's having chest pain, and we wait an hour on the stretcher before we can offload him to a nurse or even to a bed, just because there's just no bed availability, and you sit there and you wait and you wait and you wait until a bed becomes available while a patient's on your stretcher with chest pain. So again, hospital wait times can be a big stressful situation, which you're like, now I got to sit with this patient for another hour in the hospital, and you can't just leave and bring them to another hospital. Once you've crossed those grounds, then they're bound under EMTALA, and they can't be transferred out without a physician assessing the patient and then transferring a patient to a different facility. We'll get into that in medical legal. Some stress reactions. Obviously, acute stress reactions occur during a stressful situation. Remember, you need to be that duck on the water where you are calm, cool, and collective on top and 100 miles an hour underneath the surface. Delayed stress reactions manifest after stressful events. So you may have a stressful event and you do perfectly fine through it, and then eventually you may have that breakdown where you just need to step aside. If you need to go outside, you might cry a little bit, whatever it takes to kind of have that delayed reaction and kind of get through it. The other one is the cumulative stress reactions, which are prolonged or excessive stress under a certain amount of time. Eventually, when you're so stressed out, you're going to break at some point, and that's where your prolonged or excessive stress comes into play. Post-traumatic stress disorder can definitely develop PTSD. Critical incident stress management was developed to decrease the likelihood of PTSD. These are out there. They're becoming more and more popular now compared to what they used to. Again, just if you need help, we can call for a CISM meeting. As you can see in the picture on this slide, this is a CISM meeting. With that, there's no cell phones. If there is food or drinks, it's all healthy stuff that you can eat. Donuts, sugary drinks are not supposed to be part of a CISM. And this is not a critique of the call. It's for you to talk about how you're feeling and work your way through it. That's what it's there for. If they start critiquing a call and saying you did this wrong, you did that wrong, then this is not the right kind of meeting. And even if you don't feel like you need one, somebody else may, but your fire chief or EMS chief or supervisors can actually call for these meetings either way, have it set up, and then you have the choice of either going or not going. These are not mandatory meetings. Warning signs of stress, obviously irritability towards coworkers, family, and friends, the inability to concentrate, difficulty sleeping at night or increased sleeping, like long-term sleeping, or nightmares, feelings of sadness, anxiety, or guilt, indecisiveness, loss of appetite, loss in interest in sexual activities, isolation, loss of interest in work, increased use of alcohol, recreational drug use. Some physical symptoms such as chronic pain, like headaches and backaches, and feelings of hopelessness. These are all different warning signs of stress. If you notice yourself having these, you could be in a stressful situation, and your best option is to find a way to just relax at this point. If it gets really bad, there's nothing wrong with actually talking to somebody. And maybe talking to, like, if you're a church person, seeing your pastor or leader of the church or someone in the church group, to talking to a psychiatrist or just somebody who can listen. They also have open phone lines available as well, talking to a good friend, whatever it takes to kind of help relieve some of that. Emotional aspects of the emergency care, obviously personal reactions to difficult situations are difficult to overcome. This is normal, and every EMT must deal with these types of feelings. It happens even up to the paramedic level. There's situations you're like, I don't know how to overcome this. It's okay. Just remember you have outlets and talk to people. So other stressful situations, many situations are stressful for everyone involved. Use extreme care in the words and actions that you have, and bring a sense of order and stability to the situation that's currently there. Try to make sure you have some order. Make sure that things are calm. Do the best you can to control the situation. A patient's reaction is influenced by many factors. Some of those factors may be how you present yourself in the situation that's stressful. Because if you start freaking out and you're supposed to be the professional that's there, then they're going to start freaking out saying, oh my God, this is really bad, or oh my God, this EMT does not know what they're doing. So it could go either way with that. Allow patients to express fears and concerns. Be that listening board for them. Let them talk to you. Transport parents with their children. If at all possible, if the parent can come in the back of the ambulance, let them do so. Uncertain situations, if it's unclear whether a true medical emergency exists, you don't really know what's going on, contact medical control about the need to transport. If in doubt, transport. There's nothing wrong with calling medical control at the hospital and consulting them with the current situation to find out their thoughts. Calling a paramedic or calling an advanced EMT on the phone saying, hey, what should I do? that is not medical control. You need to contact a physician, speak with a physician at the hospital, and have a conversation with them. Utilize them. They're there for your help. And on top of that, it helps with the medical legal part of it, because now you pass it on to a higher license to help make a decision on what's going to happen. Violent situations are created by civil disturbances, large gatherings of potential hostile people, domestic disputes, and crime scenes. You will run into situations where patients become violent, whether they overdose, you wake them back up with Narcan and they become very violent with you. You may go to large gatherings where there's fights, or the simple domestic dispute, where you show up. A lot of times with these types of situations, if they know about it ahead of time, they have you staged for PD. You'll stage and wait for PD to clear the scene. And once the scene is clear, then you can go in and start your evaluations. Usually they get in there and try to separate the people, get ready to calm down before you guys come in and start your assessments. Know who's in command. Protect from dangers to provide care. So law enforcement secures the scene before you enter, or uses cover and concealment techniques. Call for additional help if needed, and do not disturb crime scene evidence. If there's a crime scene, a lot of times, and remember, anytime you have like a suicide, whether it be a hanging, gunshot, whatever it may be, that's still a crime scene. There's evidence. So if you have to turn the body over to do stuff, you can do that. But again, you've got to document and let the law enforcement officers know what you've done and how the patient actually was prior to. Behavioral emergencies are becoming a lot more common than I've noticed, as far as psychiatrics and things like that. I've seen a lot of psych patients because of COVID now, and not because they had it, because of their fear for it. I've seen a lot of those coming through the hospital when I was working in the ER. So emergencies that do not have a clear physical cause. So the cause may turn out to be a physical, could be hypoglycemia, it could be a head trauma. So anytime there's a type of behavioral emergency, we definitely want to get a blood glucose and do an assessment. But use caution with these patients, because patients that have behavioral emergencies, whether they're bipolar, schizophrenic, manic, things like that, there may be their behavior is unpredictable, so you don't know what's clearly going to happen. So make sure you keep a distance as best you can. Protect yourself when you're on scene. And if you think you need law enforcement, then make sure law enforcement's available to you. All right, workplace issues. Cultural diversity on the job. Each individual is a different person. Everybody has their own beliefs. So communicate respectfully and use cultural diversity as an asset. Have conversations, talk about work. Eventually get to know people a little bit more on your shifts, and you'll know what you can and can't say to them. But again, just be respectful. That's the biggest thing with workplace issues. Cultural diversity on the job. Diversity is an effective way to strengthen a public safety workplace. So understand how to communicate effectively with coworkers from various backgrounds. It's not a bad idea to get to know who they are. So if you're going to be with them every shift, every week, it's a good idea to kind of learn who they are, what they do, likes, dislikes. That way you can learn to make a better working atmosphere. Sexual harassment, there are two types: quid pro quo, requests for sexual favors. So if I do this for you, you do this for me, I get you a promotion type thing. Hostile work environments, joking, touching, things like that. Any kind of harassment is reported to your supervisor immediately, and they keep notes with all that stuff. Substance abuse, obviously increased risks on the job, which leads to poor decision making, which then can turn into bad patient outcome. So seek help or find a way to confront and add an addicted coworker. Employee assistance programs, EAPs, are often available as well. So if you notice that a patient's turned to alcohol, a coworker has turned to alcohol, and I'm not just saying a drink here and there, drinking heavily every night just so they can get to bed. There are programs out there that are available through employee assistance programs that can help with this type of situation to get them back on a normal track. Suicide prevention, and I know that you guys, most of you guys are on Facebook and have seen a lot of the EMS providers with suicide and things like that. If you need help, reach out to somebody. Cumulative stress and acute intense stress can weigh heavily on an EMS provider. With this, they may say, enough's enough, and they end up ending their life. So if you or a colleague expresses suicidal ideations, make sure you seek professional help, right? Elements of an injury and illness prevention program, obviously management leadership, worker participation, hazard identification and control. Hazard prevention and control as well, education and training, and program evaluation and improvement. So taking a look at the chat box really quick, I saw that Kim posted that to everybody. Did everybody get a chance to see Kim's post on that?
Yes, I did.
All right. So I'll read it out in case people haven't looked at it.
Yes.
It's a reference of part of talking to someone. She's part of the York County support team for law enforcement. This also includes dispatchers, firefighters, etc., who need help with a traumatic incident. Everything will be confidential. She's wanted to let everybody know that that's an offer out to everybody. So awesome, Kim. Thank you for pointing that out.
And if anybody does have me on Facebook or anything, you can reach out that way. If you don't feel comfortable talking to me about the incident that took place, I have many other resources, and I can reach out to them and see if that's a good fit for you if you prefer talking to them.
All right. Thanks, Kim. All right, so in review, a disease that can spread from one person to another is known as a, you guys can answer this one here. What are your thoughts?
B.
All right, so the answer is B.
B.
Disease can spread from one person or a species to another. Let's go to number 2. All right, the most effective way of preventing the spread of disease is
A.
right. I heard a lot of A's right there. A is the correct answer. According to the CDC, the most effective way of preventing the spread of disease is through hand washing, especially in between patients. Up-to-date immunizations and PPE will minimize the risk of contracting the disease. All right. While caring for a trauma patient, the EMT has blood splash into her eyes. This is an example of what type of exposure?
B.
Exposure. B.
Yes. Doesn't give you the answer. Right. Let's see. 4. Protective measures that prevent healthcare workers from coming into contact with germs are referred to as
B.
D.
I heard B and D. The answer is B. Standard precautions prevent healthcare workers from coming into contact with germs. All right. So what is the second stage of response in the stress response known as the general adaptation syndrome?
That one I'm not sure about. I'm going to go with C.
I'd say D.
Yeah, the answer is D. Right, a condition characterized by re-experiencing an event and over-responding to stimuli that recall the event is called
D.
I'm going to go with D.
D is the answer, PTSD. Blank is the fuel to make the body run. I know there's caffeine's not on there.
D.
D.
The answer is C. To perform efficiently, you must eat nutritious foods. The physical exertion and stress of your job require high energy output. Which stage of grieving commonly results in blame?
B.
A.
I'm gonna go with B.
B. A. The answer is B. The person may lash out at the EMT or blame the EMT for an unfortunate event. Number 9. Placards are used on
A.
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 Yeah.
Used on buildings and transportation vehicles.
Oh, okay. I was gonna say I thought they were used on vehicles too.
Yeah. All right, and number 10, the 5 most common hazards associated with a structural fire include
A. A.
A.
Okay.
I'm gonna go with C, just be different.
Yeah, it was definitely A. I like it. All right. So any questions with this chapter at all?
Not right now.
No.
All right. So we're going to take a 10-minute break. I got to get this chapter fixed, stop the recording and all that too, and then we'll move on in about 10 minutes.
Sounds good.
All right. See you in about 10. So some of the national components we need to follow, our preparatory stuff, is applied fundamental knowledge of the emergency medical services system, safety and well-being of the emergency medical technician, medical, legal, ethical, and issues to the provision of emergency care. Medical, legal, and ethics, obviously consent refusal of care, confidentiality, advanced directives, tort and criminal actions, evidence preservation, and statutory responsibilities. Mandatory reporting, ethical principles, moral obligations, and end-of-life issues. So these are kind of the competencies we need to cover throughout this chapter. So a basic principle of emergency care is to do no further harm. When we get on scene providing care to a patient, we cannot provide further harm to this patient. We need to provide a positive outcome, hopefully. Now, not everything we do will come out positive at the end. Patients can still die, even though we put our best forth efforts to the patient, following protocols and knowledge, skill level, and things like that. A healthcare provider usually avoids legal exposure if he or she acts in good faith and according to an appropriate standard of care. So the DOT, again, says that we have this standard of care we need to follow, but it's a standard of care that they set to the state, or the state says, all right, we're going to follow these standards of care, and we're going to add additional skills to the provider level. So we follow the standard of care based on the DOT curriculum. However, we also follow state protocol, which is governed by the medical boards from the state level. The EMT is often the first link in the chain of pre-hospital care. That goes from EMT to paramedic, wherever ambulance you're running. We're the first link of care because we're the first ones to get there. We're the first ones to make an assessment, and we're the first ones to start treatment before the physicians see the patient. So this is why it's so important to make sure that our documentation is where we need it to be, and anything else that we do, because we may actually make a positive outcome to that patient, and may also help with the treatments that the hospital does as well. To avoid civil and criminal actions, provide competent emergency medical care that conforms with the standard of care that is set forth by the state. Consent is permission to render care. So you can't just walk up to anybody and start touching them and start providing care. You need to get consent. A person must give consent for any kind of treatment, and if the patient is conscious and rational, he or she has the legal right to refuse care or refuse certain types of care as well. Consent, foundation of consent is decision-making capacity, can understand information provided, and can make informed choice regarding medical care. The patient autonomy is the right of the patient to make decisions about his or her health. They have to be alert and oriented ×4. So a person, place, time, and event, and be able to communicate with you and have an understanding that if these services are declined, that the results of injury or illness that you may have sustained could result up into including death. If they can understand that and understand that they turn around and walk away, that they could die 2 seconds later, it is not on you anymore at this point in time. Please sign here. And they sign a release of care form. Now, what's happening is you're signing off what they call AMA, which is against medical advice. Other options that you can utilize for this, though, okay, is if you have a patient that really needs to go to the hospital, you're like, this patient's sick, they really need to go, but they're alert and oriented, they won't go to the hospital, maybe because I'm an EMT, they're not listening. You can call medical control, put them on speakerphone, and have the medical control physician talk with the patient to try to convince them to go to the hospital. A lot of times a physician may actually have more leeway and pull with their medical knowledge with that whole MD title, that a patient may listen to them. And they may say, oh, you know what? You're right. You're a doctor. You said I need to go here. And this is what happens. So utilize this as far as trying to help them understand they need to go. The patient acknowledges he or she wants to provide care and transport. This is express consent. So this means that they've said, hey, we want you, we want to go to the hospital. Please treat me. This is how you get express consent. To be valid, the patient must provide informed consent where you have explained the treatment risks and benefits to the patient. So if you go, this is going to help better your ability to survive. If you don't go, this could happen, and it could result up into including death. And then make sure they understand those different types. Implied consent are for patients who are unconscious, otherwise incapable of making an informed decision. So they may not also be just unconscious, but they could be altered mental status due to diabetes, having a diabetic emergency, and on top of that, they lost my train of thought for a minute. So altered mental status, ETOH. Now, can you be under the influence of alcohol and still be alert and oriented? What do you guys think?
Yes, depending on your level.
Yes.
So can we actually check blood alcohol content in the field, though?
No.
No.
Right? We can't. So that's the thing. So if you're coming into a contact with a patient who is ETOH, okay, or alcohol in the breath, they appear to be intoxicated, but they can hold their own, and they're making all the right decisions, they understand what's going on, contact medical control and say, I have an ETOH patient, they're alert and oriented, they do not want to go to the hospital, they've answered all my questions appropriately, what would you like me to do? 99% of the time, the ER physician is going to say, go ahead and get the refusal against medical advice and make sure they understand the risks of not being transported, and make sure you, and then verbalize it again. Document the physician who spoke with you, whether, I'm going to use Dr. Chen, because that's our medical director for the ER at Huggins Hospital. I document his name. This is what he told me on the phone. It goes into your run report. So, again, if they're ETOH, they may not need to go to the hospital, depending on if they're informed and capable enough to make those determinations. Now, After they've signed off with us, what law enforcement does with them afterwards, well, it's on them. So that's what's going to happen from that point. There's other states, though, that have different rules, and I'll bring those up just really quickly. Massachusetts PD can do something called a Section 9A. A Section 9A means that a PD officer can force a patient to go for a medical evaluation, which is interesting, versus a Section 12 down there, which is psych. But a Section 9A, they can force anybody to go to an ER to be evaluated. They can walk out when they get there, but it requires them to be transported. And I've run into that a lot in Massachusetts when I worked down there as a medic. We don't see that up here. There's different things for psychiatrics, like blue papered. I think it's still called blue papered in Maine, where they go to the hospital that way, or in New Hampshire, it's called an IEA, where the patients go. They get forced to go to the hospital for a medical evaluation for psych. Implied consent should never be used unless there is a threat to limb or life. Again, principles of implied consent is known as the emergency doctrine. So it means that they're implied, they're unresponsive, and in their good judgment, if they were alert and oriented, they would want us to take them to the hospital. That's where we use that implied consent. A good idea to consent from a spouse or relative first. Most of the time, the spouse or relative will say, yes, take him. But if not, and there's no one around, it becomes implied. Involuntary consent is what I was just talking about. Applies to patients who are mentally ill, in a behavioral crisis, or developmentally delayed. So they have like Down syndrome or things like that, autistic, Asperger's, things like that could make them so they can't make their own decisions, be involuntary consent. Again, every state's a little bit different, from blue paper to IEAs to Section 12, depending on what state you're working in. Just understand what your local laws are, or your state laws are, with those kind of patients. If a patient makes a threat for harm on themselves, and there's text messages, there's proof that they have made some kind of threat for suicidal ideation, or even if they were homicidal, they're going to be transported to a hospital. So again, those are patients that are going to get blue papered, IEA'd, or sectioned, and they're going to be going to an ER for mental health evaluation. Obtain consent from guardians, always. Not always possible, so understand local provisions that are there. If you have a minor and there is no way to contact family or a relative of some sort that can make decisions for that patient, they get transported to the hospital. Even if they're involved in a motor vehicle accident, they're 17 years old, they're not emancipated, and you can't get a hold of mom or dad, we transport them to the ER. Unless PD is willing to take custody of the patient. And not all the time do they do that around here. In the bigger cities, they don't do that at all because they're too busy to take care of that. So what they'll do is they'll pass it off to EMS to transport. Minors that consent, so a parent or legal guardian gives consent to transport, even if the kid doesn't want to go. If the mother or the guardian, the parent, says they're going to the hospital, they're going to the hospital. In some states, a minor can give consent depending on age and maturity. Emancipated minors, married, armed services, or parents can do that as well. And teachers and school officials may also act in place of parents. So the parents have given consent or permission for the teachers and or school nurses to make consent for transport. A lot of times you'll see that at like a summer camps, that they'll give them, because whatever, if they're gone for, like, say they send their kid to camp for 3 weeks or for a month, they'll give consent to the staff to make the most appropriate decision. Up in the area that I work in up here, there are so many, there's probably about 7 different summer camps up here in this area we get called to quite often, where we get there and they're like, yeah, the parents already gave us permission to send them to the hospital. So let's make sure you document all that appropriately. If a true emergency exists and no consent is available, treat the patient, and consent is implied at this point with a minor. Forcible restraint, sometimes necessary with combative patients. So if you are at the EMT level and we're going to be using 4-point restraints. The way this guy is restrained to the stretcher is probably not the best option. Normally, you put one hand above, one hand below for that. And then you secure the legs down. So in a 911 setting, an emergency setting, you do not need medical control, either Maine or New Hampshire, to secure someone into a stretcher with restraints. If you're doing this in Maine through an interfacility transport, you're taking a psych patient that might need to be restrained, you have to get an order. And that usually will be on your EMTALA form for transport, order for restraints if needed. Sometimes if they're that combative and they're a danger to themselves and others, you may need to call for paramedic response for conscious sedation for these patients to help transport in a safer manner. There are many medications that can be utilized for conscious sedation, to include Ativan, Versed, ketamine, things like that, to the point where they can actually be sedated, paralyzed, and intubated just for protection. It's called punitive care, for protection for everybody else. Legal permissible, consult medical control. This is all legal to do and may require law enforcement. If law enforcement is with a patient and they are handcuffed to the stretcher or handcuffed in the back of the ambulance, by New Hampshire law, the law enforcement officer has to be in the back of the ambulance while transport, not following behind in a cruiser. They have to actually be in the patient compartment. So if something happens, they can take off the handcuffs to be able to treat a patient. So a lot of times they'll uncuff the patient and we'll do restraints like you can see on the picture here. So their law enforcement doesn't have to ride in the back of the truck, but they might follow over behind you in case something else is needed. So know your local laws about forcible restraint, and if restraint is used, protect the patient's airway and monitor the patient's respiratory status. Back in the day, years and years and years ago, we used to put patients face down. We used to put them on a backboard, on their backboard on top of them to hold them down and restrain them. That way, those have gone out the window many years ago because what was happening is patients were suffocating. You also got to think of positional affixia as well, where if you have a patient that is very heavy and they are on their stomach or they are laying on their back, they can no longer breathe because of their body weight. It holds the chest cavity down to where they can't breathe and they become hypoxic, which is positional affixia. So what happens, what you need to do here is sit these patients up in a either semi-Fowler or Fowler position in the stretcher and still have them secured down. That's why in some of these patients, depending on how bad it is, paramedic response is probably some of the best options to get conscious sedation done. Does that make sense, you guys? There's a lot. I mean, I just put out a lot of information there.
Yeah, it does.
Okay.
Yeah.
And again,
And also,
go ahead.
sorry.
No, you're fine.
With the law enforcement aspect of restraining patients, I know in Maine, I don't think that they get authorization before restraining to the stretcher in the back of the ambulance, and we typically, it's up to the EMT that is going to be doing the transport if they want us in the back, or if they're going to be all set if we just follow right behind. But either way, we have to be within reach of like the ambulance, I guess, in case of an emergency. I don't know, Honor can shed light if that's incorrect or not.
Yeah, thanks for the insight. If you see something also throughout this presentation on the law enforcement side and you want to jump in, feel free to.
Okay.
All right, so the right to refuse treatment. So conscious alert adults with decision-making capacity have the right to refuse any treatment. Can also withdraw from treatment at any time, even if the result is death or serious injury. Let me go one step further into this, though. If you are transporting a patient, okay, they may say, all I want is BLS. I don't want any pain management. They don't have to get it. I don't want an IV. Well, they don't have to get it. I don't want a cardiac monitor. They don't have to get it. The ultimate goal is getting this patient to the hospital, right? That's what our goal is. So with that being said, patients can refuse specific treatments on the way to the hospital, or they can refuse all treatments together. They may say, yeah, take me to the hospital, but I don't even want vitals done. If they don't want it done, you can't do it. But at least we're getting them to the ultimate goal, and that's our goal, is to get them to an ER. So now, if they become altered or go unresponsive, at that point we have implied consent, and we need to treat. You know what I mean? So again, this also places the burden on the EMT to clarify the need for treatment as well. So they may not even allow you to get a full assessment in. Assess the patient's ability to make informed decision by ask and repeat questions. Assess the patient's answers and observe the patient's behavior. So what we're saying is, I usually do month, day, year, president, person, place, time, and events. If they can't answer all 4 of those, they're not alert and oriented. I also throw the Glasgow Coma Scale in there, looking at eye movement, verbal response, and motor function as well. We'll get into the GCS scores when we get into assessments. Can they do all this stuff appropriately? If they can, then we're good. Another thing you can do is assessing short-term memory by checking every 5 minutes. So you could say, I want you to remember these 4 items or 4 things. You can say apple, pineapple, penny, quarter. And in 5 minutes again, say, remember those 4 things I asked you to remember? And see if they remember what they are. Just make sure you jot them down yourself so you know what they are. But again, that can check short-term memory loss as well. If the patient appears to be confused or delusional, you cannot assume that the decision to refuse is an informed consent or informed refusal. Right? We do not do informed refusals like that because if the patient's delusional, are they really conscious, alert, and oriented? Suicidal patients should not be regarded as having normal mental capacity. Right? People just don't go around saying, I'm going to kill myself today. That's just something else is going on. And it might not be that they're psychotic or crazy. They could just be very depressed, and they may just need someone to talk to. And the hospitals can put them in a safe space, and what they'll do is they'll have someone come in and speak with them. So because I've worked in New Hampshire for so long, the New Hampshire system, if a patient goes to the hospital, they're going to get an evaluation from Northern Human Services, and that's done through video conference. So what happens is you take a patient into an ER, they're evaluated by a nurse, or in this state here, paramedics can also work as nurses in the ER. They do an evaluation, they go through the whole process, they get blood work done, they have to get consent, but they can get a blood draw done by the lab, they also get a urine sample, they do a tox screen, and they just do a normal panel stuff they have to do. They are evaluated by the physician, and if the physician feels a psych evaluation is needed, then they get on the phone with Northern Human Services. They come in and they do a video conference. And then they determine what's going to happen from there. And they can say, yeah, this patient has to be on a hold, and they'll put an IEA in, and that means they have to stay there until they get placed in a psych facility. Or the physician can say, you know something, there's really nothing wrong with this patient at all. They're just having a bad day. They really don't want to hurt themselves. They've had no plan. They just said this out of context to kind of get attention. And the physician can release that patient to go home. That's kind of the process when you get into the ER side of it and what you're going to be bringing patients to, if that helps at all. Providing treatment is much as more defensible position than failing to treat a patient. So do not endanger yourself and use the assistance of law enforcement, right? You need to protect yourself, but I'm not saying go hit your patient on the head with a clipboard. You need to be able to make sure yourself is not in danger as you're entering a room to a patient that is having a mental capacity or doesn't have a normal mental capacity. Make sure that the exit is behind you so you can exit quickly. Do not put yourself in a situation where the patient is blocking your means of egress out. All right? And always work together. Have a radio with you as well to call for help. Before you leave a scene where a patient, parent, or caregiver has refused care, encourage the individual again to allow care. Ask the individual to sign the refusal of care form A witness is valuable in these situations, and document all refusals. The witness part is pretty important. If at all possible, if law enforcement is willing to sign, and depends on the service, have them sign as a witness, because if it goes to court, the law enforcement officers are used to being in a court system like that versus, family members and or other EMTs that have never had to deal with a court case before. So if it has to go to court, it's always good to have a law enforcement officer sign a witness of refusal. If not, the last person you want to have sign is your partner, because you could say, you could guys have had a discussion. This has been brought up before. We're responding to a call for a patient. It's the end of shift. Hey, we want to get out of shift early. On time. We don't want to have to transport the patient and be out 3 hours later. So we're going to get a refusal on this. Doesn't matter what it is, we're getting a refusal. And then you and your partner talk this patient out of going to the hospital, and the patient dies. And you sign. So be careful on how you get your witnesses to sign stuff. It's good to get family members, but law enforcement should be first if they're on scene and they have the ability to do so. Again, not all law enforcement agencies allow them to sign. I know some of the cities I worked in Mass, their supervisors told them you are not to sign patient refusal forms. So confidentiality. Confidential information includes patient history, assessment findings, and treatment provided. So we can't really give this stuff out. However, you notice how I've been talking about certain calls. In an educational standpoint, we can utilize different calls as a teaching point, as long as we don't mention name and address of where we found the patient. Information generally cannot be disclosed except if the patient signs the release, if a legal subpoena is presented, and if it is needed by billing personnel. So let me ask you this. Here's a question for you guys. You're sitting at the station, you just completed a call. A law enforcement officer shows up and says, hey, I need a copy of your report. You give it to him?
No.
No,
That's it.
not at all. It has to be subpoenaed. Okay, you cannot do that. And on top of that, a lot of services also have a policy in place that the only person that can release a run form is the fire chief or EMS coordinator. So again, you don't just start printing off reports. What if a patient comes in to get a report?
No.
Unless they're the patient.
If they're the patient, you still need to follow your local policies within your agency. So it may have to come from from your chief to print this stuff off, and they have to sign a release form as well. That way there is documented they came in as the patient and they are taking a copy of their run report. And obviously billing, because billing has to be able to bill insurance companies, so they have the right to see certain aspects of the run reports for billing purposes. So here comes Hipaa. Hipaa is something that you don't deal with really unless you're dealing with interfacility transport, and it's only from hospital to hospital. Hospital to nursing home is not a Hipaa, I should say Hipaa. I'm thinking of EMTALA. Disregard what I just said. Hipaa is covered underneath everything. So the Health Insurance Portability and Accountability Act of 1996, which contains a section on patient privacy, which also strengthens privacy laws, safeguards patient confidentiality, and considers information to be protected health information, PHI. HIPAA is followed by everybody. So disregard what I said about that. I was thinking of EMTALA, so I apologize. So with that, we cannot release any of this information unless it's for billing practices. So if you have a bad call, we can't go back to the local store and say, hey, guys, we went to this residence for this, and this patient got transported to the hospital. Or they may say, hey, was there a call at this person's house earlier today? You got to say, I can't discuss it. You can't tell them no. You can't tell them yes. Just say, we're not allowed to discuss anything that happened throughout the day. However you want to word it. I mean, it kind of gives it away if you say we can't discuss it. But you just got to make sure you word it to the point where you're not getting yourself into trouble. You may be legally mandated to report your findings. Once you are a licensed provider, you are considered a mandated reporter. which means Department of Health and Human Services, elderly abuse, anything like that you may see in a home. You're obligated by law to report these findings. Release only the minimum amount of information necessary when you report it. Okay, so when you make the phone call. I've had quite a few where I've had to call in or working in the emergency department and or working in the field where we've seen stuff and had to report it. And I can bring up one case where I was responding to a call. It was at a daycare center where this kid was, 1-year-old, was severely burned by hot water. They never called for an ambulance. They contacted the parent. The parent was 45 minutes out, showed up. They said it wasn't that bad. And this kid had about 60% burns all over the body. So with that being said, that had to be reported because why was a 1-year-old being burnt by hot water? So you may have to have those types of calls where you have to report this type of situation. Advanced directives are going to be important information as well for you to be able to obtain. There's DNRs, DNIs, and DNHs. There's all different ones that are there. So we'll cover the DNR first. So an advanced directive specifies treatments treatment should the patient become unconscious or unable to make decisions. So you may find this in living wills. You may find this information there, Dnr Orders as well. So do not resuscitate order is an advanced directive that gives permission not to resuscitate. Do not resuscitate does not mean do not treat. So if they are unconscious, you can still treat them, but they may not want, but they don't want CPR done if their heart were to stop. Does that make sense?
Yes.
Okay. They also have things called do not intubate, which is DNI. And you'll see that more in an advanced directives form where they may say, we don't want any advanced procedures or invasive procedures like CPAP. Well, CPAP in New Hampshire is a basic level skill. So they may have advanced directives on there saying if you were very hard to breathe, like a COPD exacerbation, they may only want a non-rebreather placed. They don't want to have anything invasive like CPAP or be intubated. The other one is do not hospitalize. That does not mean that you don't bring a patient to the hospital. The hospital cannot admit that patient for any circumstance. So it's kind of like fishing when you catch and release. It's the same thing. The hospital catches the patient and releases them back out. So that's kind of how that works with do not hospitalize patients. And a lot of times you'll see that with patients that are on hospice, where they'll go to the hospital for some kind of treatment, and they'll be sent back home on hospice care. Other names for advanced directives would be a living will or a healthcare directive. You may also have different people as well that can make certain medical decisions. And if you have a patient that's elderly, they may have a DPOA, which is the durable power of attorney. The durable power of attorney, which is whoever it may be, is able to make medical decisions on behalf of the patient that is there. Now, a lot of times you'll see DPOAs of patients that have Alzheimer's or dementia, where they can't make their own medical decisions on their own as well. So DNR orders must meet the following requirements. One, a statement of the patient's medical problems have to be listed on it. Signature of the patient or a legal guardian has to be on that form as well. A signature of the physician or healthcare provider, and then the DNR has to be not expired. Now, I'm going to ask you this. You respond to a residence, let's say for an 80-year-old male who is unconscious, not breathing, and you get to the residence, you notice there is no pulse. You ask the family members for the DNR, and they cannot present it to you. Do you do compressions or not?
Yes, you did.
Yes.
Absolutely, until it is presented. However, you still want to consider a couple of things. If the patient's stage 4 cancer,
Can he see you?
what was that?
He can hear you though.
So if you have a patient who's stage 4 cancer, cardiac arrest, and you start working it, the family's freaking out saying, oh my God, I can't find the DNR order anywhere. Please do not do CPR on them. Start going through the motions, call med control and say, listen, I got a stage 4 cancer patient who's on hospice. They can't find the DNR. Do you want us to continue CPR? And they're probably going to tell you, no, stop. But at least get the order from a physician over the phone to stop compressions. All right. So that's what needs to happen with that. Ooh, wrong button. There we go. So advanced directives, you may see something like this here, photos and whatnot. Maine and New Hampshire have identical DNR forms for the most part, and they're pink. Most of the time they have a portable DNR, so it's more like a smaller piece like we see on the screen here, versus the full DNR. That has to come with you in the back of the ambulance. So if something were to happen during transport, you have a copy of that, and it also has to go to the hospital. For documentation purposes, make a photocopy of that DNR and attach it to your run report. Remember that your run reports are all legal documents, so they can be attached to that. You're not violating Hipaa in any way. There's also something called a physician's order of life-sustaining treatment, which is a POLST, or a medical orders for life-sustaining treatment, which is a MOLST. These explicitly describe acceptable interventions for the patient. This is where I was talking about earlier about the do not hospitalize, do not intubate, no CPAP, things like that. These are where you'll find more descriptive medical procedures that can or cannot be done. Must be signed by an authorized medical provider, and contact medical control for any kind of guidance you may have on that. Just give them a call. Some patients may be named surrogates to make decisions for them. Durable power of attorneys for healthcare, also known as healthcare proxies. This is a good question to ask them, because you may be on scene with someone who's a caretaker there, but may not be the DPOA. So if let's say they have an in-home health caretaker. So you get there, and you want to find out who the DPOA is, and then you give them a phone call as well. And usually it's like, like a parent, or it's or one of the siblings, or whatever it may be, a child. So if it's elderly, it could be one of their kids. That's a DPOA, things like that. So just you want to find out who they are, get them on the phone, have a conversation with them, and things, kind of work your way through it. A lot of times, if a family member can actually convince a patient to go to the hospital as well. Due to the growing number of hospice home health programs, you may face this situation where people live at home in a hospital bed and they're going to die at home. A lot of them, that's their wish, to die in their own residence versus dying in a nursing home or a hospice center. Or there they can be around family. Physical signs of death. A physician determines the cause of death, not us. We do not determine the cause. We can only pronounce them dead in the field. Our presumptive signs of death would be unresponsive to painful stimuli, lack of carotid pulse or heartbeat, absence of breath sounds, or no deep tendon or corneal reflexes. So checking deep tendon reflexes or checking the corneal reflexes around the eyes. Other one would be absent of eye movement. There's no systolic blood pressure. There's profound cyanosis, which is blue. Lowered or decreased body temperature. So how do you think we need to check a body temp for that?
Rectal?
Rectal temp. If you want to get a true core body temp, if you're going to go temperature-wise. Definitive signs of death, as you can see here, this is called lividity, which is blood setting. So the blood is no longer circulating and settled to one part of the body, which usually, this patient here is most likely laying on their back when this happened. A body in parts, so decapitation. I mean, obviously, if their head is laying somewhere 15 feet away from their body, I would assume that they're dead at this point. Rigor mortis, which is stiffening, or decomposition. So you can tell by them decomposition of the body itself starting to deteriorate. And you can actually, and that's a smell that you'll never forget when you walk through a door. And the thing is, you may find bodies that people that have been dead for months in a house where they live alone, no one checks on them, and someone says, "Hey, I haven't heard from Grandma in 3 months. Why don't we send PD to go check on her?" And they walk in and find her decomposing in a chair. So this kind of stuff does happen. Medical examiner cases involvement depends on the nature and scene of death. Anytime a patient passes on, the medical examiner is called. Now, keep in mind that we don't make those phone calls. It would be law enforcement and or the hospital makes those phone calls to the medical examiner. And they have the right to say, yes, we're going to come in, or no, we're not going to come in. So I know normally in the ER, when we call the medical examiners, they would say, what was the nature of cause? Well, presumed cardiac, no medical history, no foul play. They may say, yeah, we're not going to come in, we're all set. Or they may say, oh, it's a 30-year-old cardiac arrest. We don't know how they coded. Yeah, we'll be in for the medical to do the pictures and everything else. So the examiner is notified in cases of dead on arrival, DOA, they get notified. Death without previous medical care, suicide, violent death, poisoning are known or suspected. Death from accidents they get notified on, suspicion of a criminal act, and anything with infant and child deaths are automatically notified as well. Some special situations, maybe organ donors express a wish to donate their organs. You'll find this on their driver's license, or they have an organ donor card. Your priority is to save the patient's life. Remember that organs need oxygen. So if they're an organ donor and they die in the back of the ambulance, sometimes it may be necessary to keep ventilating them to provide oxygen. But again, call med control, find out what they'd like you to do. Say they're organ donors, they passed away in the back of the ambulance. Do you want us to keep working it for now to keep blood circulating until we get to the hospital? These may be something you might see here for an organ tissue card. Other special situations would be medical identification insignia, bracelets, necklaces, keychains, or card indicating DNR orders, allergies, things like that. Diabetes, epilepsy, or other serious conditions. Some patients, which is new that I've seen within the last 7 to 10 years or so, patients wearing medical bracelets with a USB flash drive. And on that flash drive is all their medical information. So I saw this in one person, and I'm like, that's a pretty neat idea. Then I started seeing it more and more, where they bring a flash drive with them, and we just plug it into the computer. So every ambulance should have a computer on it of some sort now. Now they've gone more towards iPads, but before, with that. Other things you can look for are cell phones. So if you notice, I don't know much about Android. I'm not an Android guy. I'm an Apple guy. But if you have your phone and it's in a locked position, you have that ability to swipe to the side, and it will give you the option to look at a medical ID. You can have that set up on your phone, so you can see that. And the medical ID stuff will have like information about allergies, medications, medical history, emergency contact info, and it's all readily available if you choose to activate that part of your phone. So again, if they're unresponsive and they have a cell phone, look for that medical ID part of it. Maybe it might be benefit to you. Just with the patient. This is an example of a medical bracelet. So the scope of practice outlines the care you are able to provide. So in your protocol books, they have the scope of practice section where it has EMR, EMT, advanced EMT, paramedic. And with that, usually defined by state laws, medical director further defines by developing protocols and standing orders. So in your protocol books, it tells you your scope of practice, and then it gives you a protocol based on either what you can do without having to call med control, and then what you can do if you contact medical control to see if you can get orders to give a certain medication. So carrying out procedures outside the scope of practice may be considered negligent and a criminal offense. So if you're military and you're trained to do intubations and IVs and IOs and all that kind of stuff, and you're a basic EMT, you have to follow state protocol. Just because you're military trained in that does not mean you're licensed by that state to practice those procedures. So if you have a patient who requires IV therapy and you're an EMT, you do the IV, you're violating state protocol, which can become negligent, and it can also be a criminal offense if something goes wrong. So again, follow what's within your scope of practice. The standard of care is the manner in which you must act or behave. This is what we have for care. Every protocol book has a standard of care in it and what you're supposed to follow. And you must be concerned about the safety and welfare of others. The standard of care are established by local customs, laws, statutes, regulations, ordinances, or case law. Professional or institutional standards like AHA CPR guidelines. So if you look at a lot of the protocol books, they'll say in accordance with American Heart Association CPR, basic life support CPR. So if they say that, then you need to follow the American Heart Association CPR guidelines. Just like the states require for advanced care, advanced cardiac life support, they say you need to follow American Heart Association ACLS guidelines. In different textbooks like the NHTSA, so using AAOS, Brady, all those different companies that are out there, they have the standards of care. That's what we're teaching you within this program. Standards imposed by states, Medical Practices Act, certifications, licensure, and credentialing. So what they're saying here is you need to obtain in New Hampshire and in Maine now, and in Massachusetts, everything is taught to the National Registry. So you obtain a certification, but that does not give you the right to practice. You still have to obtain a state license. And licensure allows you to practice under medical direction, which is the state medical director and then your local medical directors for your service. Credentialing is going to be something that we have to do to recertify as well. So just because you hold a certification does not mean you're done. You have to then every 2 years renew your certification through credentialing to make sure you meet that standard. So there's a certain many hours per level, per category that you have to get educated in. And or with the National Registry, you can also test out at the National Registry written test every 2 years as well and test out of your licensure or your certification and recertify that way. Duty to act is the individual's responsibility to provide patient care. So once your ambulance responds to a call and once treatment has begun is when you have a duty to act. So if you're on shift and you refuse to go on a call, are you violating duty to act? Yes or no?
Yes.
Yes. If you're sitting at home and you're a volunteer firefighter, volunteer EMT, and the tone goes off, your pager activates, and you decide not to go, is that duty to act?
So,
Not at all,
No.
because you're not being paid or on duty for shift. Now, if you're, let's say you do volunteer call time and you're actually on a schedule to be on call for that ambulance, and the tone goes off and you decide not to go.
yes.
Yeah,
Yeah, you're right.
yep, absolutely. So volunteers can be held to duty to act if you're sitting on a volunteer call schedule and it's your turn to respond to a call.
Would you just end up being like a good Samaritan or something like that if you don't have the duty to act, but you are credentialed or whatever?
If you're the Good Samaritan law would cover you if you're like walking down the side of the road and something happens and you start to treat a patient, you're covered under Good Samaritans. But if you are on duty or on call to be on the ambulance, like on a shift schedule, then you have a duty to act.
But what if like you're just at home listening and you want to go help, but you're not on schedule or shit.
Once you sign on and respond to that call through a radio or I am responding to the company, then you're held to duty to act at that point because you've signed on and acknowledged you're going to that call.
Okay.
But this applies to licensed providers. If you're a firefighter, it's a whole different thing. This is all for EMS. Negligence is failure to provide the same care that the person with similar training would provide in the same or similar situation. So let's say a patient has chest pain, and I would give them as an EMT aspirin, as long as they meet the criteria. They get aspirin, and I assist with patient's own nitro. I give them oxygen for shortness of breath. And let's say you come along and you decide, well, I don't want to give aspirin. I don't want to call med control. I'm not going to give nitro. And the patient ends up having their heart attack worsens because we didn't give them nitrates to vasodilate. Would that be negligent?
Yeah.
Absolutely. That's where the standard of care and protocols are there to follow. And if you can't follow your protocols and your standard of care, then you're going to be held negligent for not treating the patient, which could also, in then turn, do more harm versus do no harm. So for negligence to be present, you have to have 4 elements. This is going to be a test question, I guarantee it. 4 elements that must be present for negligence to apply. You have to have duty to act. You have to have a breach of that duty. You have to have causation, and you also have to have damages done. Okay? So you have to have breach of duty, duty to act, damages, and cause. Does that make sense?
Yep.
If you don't
Yep.
have one of these,
Yes.
if you don't have all 4 of these, you're not negligent. All right, abandonment, unilateral termination of care by EMT without patient's consent or making provisions for continuing care. This can be taken place at the scene or in an emergency department. I'll cover that in a second. And always obtain a signature on your patient care record. All right, we always get a patient to sign. So abandonment on scene. Let's say I'm on scene with you and I'm a paramedic, you're an EMT, right? We get to the scene, and I say, I really don't want to go on this call. This patient's having chest pain. And I say, you know what? This can go basic level. This is all you. I'm gonna go back to bed. And I pass the patient off to you with no cardiac monitor, no IV therapy. I didn't give anything for pain management for the chest pain. I just said, you know what? This is BLS. You guys can take it. Am I abandoning that patient?
Yes, you are.
Yes.
Absolutely. That's a licensure suspension or termination of license for that kind of stuff. Now, let's say you guys are at the EMT level. You're bringing in a shortness of breath that resolved with oxygen. You get to the ER and you drop the patient off in the room and you give report to an LNA or a CNA. Is that abandonment of care?
Yes.
Yes.
Absolutely, because they are a lower level than you. Okay, you have to pass your patient off to equal and or higher of a certificate license level. So if you're in New Hampshire and you transport to a local hospital and you're an EMT and there's a paramedic in the ER that takes over patient care, can you give a report to that medic?
Yes.
Absolutely, yes. Because the paramedics in the ERs function as nurses and take on their own patient loads. So they are actually considered, they're paramedics that work underneath nursing scope of practice. All right. Assault and battery and kidnapping. Assault, unlawfully placing a person in fear of immediate bodily harm, like restraining somebody. So you can't just restrain anybody because you can. They have to be restrained for a certain reason. Battery is unlawful touching of a person, providing care without consent. And a lot of us are so anxious to help people, we get there and start doing a blood pressure on somebody. Once we have put our hands on somebody else, that is battery. And we can get in a lot of trouble for that. So we got to make sure that we're not then that's not the case. So when you approach your patient, hey, my name is Kevin, I'm here with the ambulance service, do you mind if I assess you? If they say, sure, go ahead, they've given you informed consent to allow that for yourself to go in and start treating them. Kidnapping, seizing, confining, abducting, carrying away by force. Transport against will. A false imprisonment charge is more likely defined as unauthorized confinement of a person. We cannot just take anybody, throw them onto a stretcher, and transport them. That is called, it's kidnapping, abducting, right? We cannot carry away by force. We cannot do that. However, if the patient is deemed incompetent, they cannot make medical decisions, you've consulted with medical control, and they do not have the decision-making capacity to go. So psychiatric patients, altered mental status, things like that, they need to go to the hospital. Can we physically put a patient onto the stretcher at this point? What do you guys think?
Yeah.
Yes.
We can. Make sure you have law enforcement present for that, because you're going to need the assistance, right? And the law enforcement officer may have other techniques to help you.
Like a taser.
Like a taser, yes. They have the power of the electric. I think my taser would hurt a lot more with defib pads, but in all seriousness, though, it's not a bad idea if the patient's that combative to call for a paramedic for sedation. I keep bringing up the paramedic thing, but they have drugs to make people go to sleep, which makes the transport a lot better when they're sleeping. And in New Hampshire, we carry a lot more sedation medications than Maine does. But Maine still has Versed and ketamine. And ketamine is a wonderful sedation drug when you give a lot of it. You just got to make sure they continue breathing for the transport. So,
Kevin, really quick on the abandonment.
yes.
If you're in a situation where in the household and the patient family starts getting violent and everything like that, as far as I know, it wasn't considered abandonment. If you backed out, radio dispatched, or let dispatch know, and you need law enforcement to come back in, you're just removing yourself from an unsafe situation. That's not considered abandonment, correct?
That is correct. Because you're putting yourself into a safer area, so you can back out. You're not abandoning the patient. You never actually left. You're just putting yourself in a safer situation, so when the scene is controlled, you can come back and take care of them.
Okay, thank you. I just want to clarify that.
Yeah, thank you for bringing that up. So, defamation. Communication of false information that damages reputation of a person, whether it be written or spoken. Defamation is bad. Please do not do that. Please do not start speaking out of terms. Defamation could happen with a false statement on a run report, inappropriate comments made during conversation. The run report should be accurate, relevant, and factual. All right. You do not put in the run report, the patient is drunk. All right. Patient appeared to be ETOH. That is perfectly fine. But if you start putting down a diagnosis or an assumption that the patient is drunk and they really are not intoxicated, what was happening is they were hyperglycemic and what they call diabetic ketoacidosis, then that could become more of a problem. So again, that's why we also do testing as well, okay? So don't start putting things in a run report, making statements about somebody, because you're not a physician, you do not make diagnosis. Accurate, relevant, and factual information only. Good Samaritan laws and immunity. If you reasonably help another person, you will not be held liable for errors or omissions. So the Good Samaritan conditions to be met. 1, it has to be in good faith. 2, without expectation of compensation. 3, within your scope of training. And 4, do not act in grossly negligent manner. And you're covered under the Good Samaritans. Gross negligence, conduct that constitutes willful or reckless disregard. And there is another group of laws that grants immunity from liability of official providers as well. Laws vary. Always consult with the medical director of what's going on. So something else to kind of put into perspective is in Vermont, there's a state law that if you hold an EMS license and you come across an emergency, you have to stop. So even though you hold a main EMS license, if you are driving in Vermont and you are and I'm going to also add this, displaying that you're a provider. So fire plates, EMS plates, fire department plates, EMT stickers on your back windshield to whatever, and you drive by an emergency scene and do not stop, you can be in a lot of trouble for that. It's actually violating the state law, so you have to stop in Vermont. So kind of keep that in mind if you're traveling. Know what the state laws are before you go in. That's why in my vehicle, I have nothing on my vehicle that represents anything with EMS or fire on it, for that very reason. Because if you're displaying it, you have to stop with it. Records and reports. So compile a record of all incidents involving sick or injured patients. We have to have records. It's important to safeguard against legal complications, and courts consider an action not recorded was not performed. Incomplete or untidy reports evidence of poor emergency medical care. I am going to go in depth on documentation for a reason, because if it wasn't put down, it did not happen. You're going to learn about pertinent negatives, and that being like, if I said, "Do you have chest pain?" You tell me no. That's a pertinent information that has a negative response. So with that, you put down, no chest pain, no shortness of breath. If you did not document it, it did not happen. And I will show you some copies of my report. I'll bring them up on the screen here when we get in the documentation a little bit later. National EMS Information System, so it's called NEMSIS, provides the ability to collect, store, and share standardized EMS data. If you're a programmer, this is a pain in the butt to follow, but for us that don't have to do programming with this kind of stuff, it's all your drop-down boxes, the ones that everybody hates the most. That's what it is. Used to improve the speed and accuracy of data collection. Data collection is a good thing because it helps us with protocols. Special mandated reporting requirements. Most states have a reporting obligation. Abuse of children, older persons, and others. Injury during commission of a felony. Drug-related injuries, and childbirth are all special mandated reporting requirements. Other ones would be attempted suicides, dog bites, communicable disease, assaults, and domestic violence. Sexual assault or rape, exposure to infectious disease, transport of patients in restraints, the scene of a crime, and the deceased. These are all things that most states have reporting obligations, whether that be with us in our normal run reports to actually contacting Health and Human Services, whatever that may be. And in your protocol books, there's actually going to be a phone number for you to who to call for these situations as well. Some ethical responsibilities, obviously the philosophy of right and wrong, moral duties, ideal professional behavior, morality, code of conduct affecting character, conduct, and conscience, and bioethics, will specifically address issues that arise in the practice of healthcare. So we got to make sure that we're following morals and ethics. Those are big things for us to be able to follow in the field, to make sure we have good character, conduct, and things like that. These require you to evaluate and apply ethical standards like your own or those of the profession. Be honest in your reporting and keep accurate records. So again, don't lie. Don't falsify any kind of document. If you didn't do something because you forgot to do it, document that. Don't put down, I gave the patient aspirin when you forgot to give it. If you didn't give it, you didn't give it. Document why you didn't give it. If you forgot, just don't put it down that you did, because now that patient might get even more at the hospital. And last thing they need is more antiplatelet aggregators to go back into the system that can actually do more harm to the patient. So if you didn't do it, you didn't do it. Just document why. So the EMT in court, you can end up in court as a witness or as a defendant. With this, the case can be civil or criminal. And the thing is that if your documentation is subpar, here's where the problem becomes. You may go to court 7 to 10 years later. Let's say 7 years later, you end up going to court for a call that you went on 7 years prior, and they pull up your run report, and all you put down was like 5 or 6 lines. Is that going to help you remember the call at all?
No.
No, not at all. So document, like every case, every call you go on is going to go to court. That's the best advice I can give you. Document your assessments, what's been going on, and everything else. And I'll show you some of the ones that I've had. Whenever called to testify, notify your local service director and legal counsel. A lot of times your service will have legal counsel that will defend you because you were on that call. But if they don't, make sure you have your own legal counsel ready to go. As a witness, remain neutral while you're there and review the run report before court. Make sure you take a look at it, because they're probably going to be asking you a lot of questions. As a defendant, an attorney is required. So defenses may include statute of limitations, governmental immunity, contributory negligence. Discovery allows both sides to obtain more information through interrogations, which are written requests or questions, or depositions, which is an oral request or questions. Me personally, not having to go through any of this in the 22 years, I'm sure Kim can probably enlighten us a little bit more on the court side of things, being law enforcement.
Yeah, absolutely. So, law enforcement side, we have to do like a narrative or our own report that's involved in any crime or anything like that. That goes into the DA's office, the district attorney's office. They review the case, and then the defendant will be given an arraignment, and then they go into court, and then depending on the charges or anything like that, we can be subpoenaed to court and have to testify. And that's pretty much the same thing explained here. And then as far as the defendant side, you personally being the defendant in like an excessive use of force report or anything like that, you're gonna have to swear under oath and have to do a verbal statement in front of a jury, grand jury, everybody. So it's pretty intense. Definitely having a lawyer present with you helps, because they will tell you the questions that are going to be asked of you ahead of time. So.
And the interrogations that are there are actually, they can be pretty intense, I'm sure.
I've never been interrogated, so I'm not too familiar. I don't believe once you do have a lawyer present, usually that won't happen. And if anything, they would request a written statement that is drawn up by your lawyer themselves.
Perfect. Well, thank you for the clarification on that. You probably went into it a lot better than I could.
No problem.
Oop, I went too far. There we go. So the most cases are settled following the discovery phase during a settlement phase. A lot of times that happens before it even goes to a trial. If it's not settled, then it does go to a trial. Damages that may be awarded, compensatory damages or punitive damages as well. Any EMT charged with a criminal offense should secure them the services of a highly experienced criminal attorney immediately. So if they're coming after you because you were negligent, you need to find a criminal attorney like right away. Find someone that's very experienced in it, and they're out there. Again, if you follow your protocols and you follow your standard of care and you do everything the way things are supposed to be done, it's very hard to become criminally negligent on a patient. It's when you start cowboying it up and start doing things outside of your scope of practice or being judgmental because, and I hate to use these words, but you know, you're dealing with a child molester. Well, we all know what we want to do with a child molester, right? Unfortunately, there's still a patient. We have to still treat them. So again, we have to follow, if we follow our standard of care, no matter who, no judgment, no stereotyping, we just do our job. It's very hard to be caught negligent for not doing something. Again, you still may go to court, but for you to have to find a criminal attorney, you may not have to have that option. It may not be there. You know what I mean? So follow your protocols, and if all else fails, med control is there for you. Call them. All right, so let's do some review questions. Then we're going to take a lunch break for an hour, and then we'll come back. We're here, so we should be done in about 10 minutes or so. All right, so you arrive on the scene of an older woman complaining of chest pain. In assessing her, she holds her arm out for you to take her blood pressure. This is an example of what type of consents?
See?
I would say implied.
Implied consent A?
Yeah.
All right, the answer is actually C,
A.
expressed. Because she didn't give you verbal consent, so it's not implied, right? Or she gave you express consent by taking your hand and putting it out to you, like she wants this done. That makes sense?
Yeah.
All right.
Yes.
Perfect. All right, number 2. Which of the following is an example of abandonment?
D.
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 All right. D. Abandonment occurs when the patient is terminated without patient care. The patient care is terminated without the patient's consent, or when care is transferred to a provider of lesser level of training or certification. To kind of add to that, okay, I want to add one more thing I should have mentioned before. If you respond to a call, let's say with someone with an ankle fracture, okay, a paramedic is there, an EMT is there. The paramedic offers pain management. The patient goes, I don't want anything for pain. Just put some ice on it, splint it, or I'm good. I don't need any more. I don't need anything at all. Can the paramedic pass that patient off to an EMT?
Yes.
Yes.
No.
They actually can. They can downgrade the call. As long as there's nothing that a paramedic can do skill-wise or pain management or things like that, they can have a BLS provider take that patient in. As long as it's documented in the run report of the paramedic who did the intercept or the EMT that pain management was offered and refused, the patient refused IV access. As long as all that stuff was offered and they refused it, it can be downgraded to a lower level of call. But they have to document an ALS assessment was done to add to that. So there are certain calls that are out there that they can downgrade. All right, number 3. The unauthorized confinement of a person is called?
False imprisonment.
C.
See a lot of C's. Answer is C. Perfect. All right, number 4. The failure of the EMT to provide the same care as another EMT with the same training is called what?
C. Negligence.
D.
D.
Mm-hmm.
C. The EMT can be held liable for negligence if he or she fails to provide the same level of care as another EMT with the same training would. An 8-year-old boy was struck by a car and is unconscious. He is bleeding from the mouth. A police officer tells you that he is unable to contact the child's parents. You should do what?
A.
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 Like it.
A.
A it is. Number 6, an advance directive is what?
A.
C.
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 All right. The answer is C. All right. Number 7. Which of the following patients is competent and can legally refuse EMS care?
C.
C.
Answer is C. Number 8. You are treating a patient with an apparent emotional crisis. After the patient refuses treatment, you tell him that you will call the police and have him restrained if he does not give you consent. Your actions in this case are an example of what?
A.
A.
A it is. An EMT has a legal duty to act if he or she is
C.
B.
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 And number 10, which of the following statements about records and reports is false?
D.
D.
D. All right. So it is 11:47 right now. So we can resume at 12:45. We'll finish up the last 2 chapters. We'll definitely be done a little before 5 o'clock today. And then we'll have some discussion at the end with that about what's coming up for Wednesday, and we'll go from there. So I'll see you guys in about an hour, 12:45.
Sounds good.
All right, check your email. So I'm going to close out this and send you a new invite.
Okay.
All right?
All right, thank you.
All right, see you in an hour.
Thank you.